All right, so we got a couple people not here today, so I'm going to just basically make a video of what we're doing. No, not necessarily. Does everybody want to say hi? Hi. Hi, Ben and Jen. Sorry you couldn't be here. All right, so let me see. All right, the first thing we're going to be doing today is looking at a video, and this video has got to do with heart attacks. And it's really, this is actually, it's not the newest video there is, but I haven't found a better one, you know, that really goes through the description of the mechanism of a heart attack, a myocardial infarction. So for that reason, I still use this Discovery Channel video that I've had for, I don't know, several years. All right, so what I'm going to do is I'm going to basically pause this video because this thing is available on YouTube, so people can take a look at that in their spare time. So we're just going to pause this, and we'll be back with you in just a few. Okay, hopefully this is going to work like I want it to. All right, I think that looks good. Okay, so, so once again, as usual, because it wouldn't be a Thursday if I didn't forget my point clicker. So of course I did. Give me a chance to forget something, and I'm probably going to jump on it. Okay, so anatomy of the heart. Arteries, capillaries, veins, and then, like we talked about last time, we saw pulmonary circulation versus systemic circulation. So we're going to look at that just briefly, very briefly. And I think I've given y'all some heart diagrams that are a little bit more detailed than this even, that show the flow of blood through the heart. So hopefully everybody's kind of got a handle on that. The heart is directly behind your sternum, a nice bony plate to protect it. The atria are the rooms where the blood returns to the heart. The ventricles are the actual, you can think of those as like the business part of the heart. That's where the actual blood flow is coming from, right and left ventricles. The layers of the heart. Inside, the inside layer of the heart, the lining of it, is referred to as the endocardium. It's endothelial tissue. The muscle part is the myocardium. And then the outside layer is the epicardium. The epicardium is in direct contact with the pericardium, which forms a sac on top of the epicardium. And we talked about blood travel and gas exchange earlier, so hopefully everybody's got a handle on how that stuff works. Now, this picture here shows a normal heart with a normal pericardial space. You know, there's always going to be some fluid in there because, like anything else in the body that moves, this thing has to be lubricated. So there's lubricating fluid in between the two layers of the pericardium, analogous to the layers that surround the lungs. Now, if there's too much fluid inside, that compresses the heart and puts it in a condition called tamponade, where it has a hard time expanding and contracting. And that can result in heart failure very quickly. So if somebody presents with a condition like this, what's the doctor going to probably do?
Drain it.
Drain it, exactly. Pericardial synthesis. Get that fluid out of there. You know, once it's down to a manageable level. Okay, look, we're not doing a course here. I've actually sat through some lectures on reading EKGs, and I still can't do it. I mean, I can kind of tell when something looks right and when it doesn't. But sometimes I'll look and I'll say, well, you know, that looks like it's abnormal. But then the doctor looks at it and says, oh, you know, that's fine. You know, that's just a normal pulse. Because sometimes when you're taking somebody's blood pressure and you're listening to their arm, even though their pulse might be something normal, it's like 70 beats a minute. And then you're listening to it with your stethoscope because you're taking their blood pressure, and it's like their heart beats like 3 or 4 times and then stops. And then it starts beating again. And that can make it hard to determine their blood pressure because, you know, wonder if you pass through that point while their heart's not beating, so you didn't catch it. Anyway, some people have an irregular pulse. That doesn't necessarily mean they're having a heart attack. That's just the way they roll, sort of. Okay, which of these looks like a normal sinus rhythm to you? I know y'all haven't been to cardiac strip class, but you know, just from watching, like, I don't know, Chicago Med. Yeah, that first one looks pretty normal, doesn't it? That's what we expect. We expect to see a little P wave bump, and then QRS complex as the heart actually beats, and then the T wave as the heart depolarizes in preparation for the next beat cycle. So, yeah, you're right. A was normal. B, okay, according to the book, it's atrial flutter, which is like a more rapid heartbeat. And then atrial fibrillation is where the atrium is not contracting. The atrium is supposed to contract a little bit. You know, whenever the heart goes into like diastole, the atrium is supposed to contract some to help push the blood down into the ventricles. If the atrium is not contracting like it's supposed to, if it's just like vibrating, it's not necessarily a showstopper. I mean, it can cause the patient to have some palpitations or you know, some difficulties with exercise or whatever, you know, and they might need to be on a lot of times people are put on, what is it, a beta blocker in order to help with atrial fibrillation. But this isn't going to be like something that's going to result in their demise, probably, at least not right away. Ventricular fibrillation, on the other hand, will result in your death. That was what happened on that video just a second ago, when the heart starts just like quivering, and it's moving, but it's not really pumping any blood. And that definitely can wind up killing somebody. And then this one down here is tachycardia. It's just a very fast heartbeat. Okay, what if I go tearing down the street and I'm running because, you know, I don't want to miss out on the 2-for-1 special down at the local bar. And my heartbeat is very, very elevated, right? Well, we expect that because I'm exercising. But if I'm sitting at my desk, you know, like working on my latest PowerPoint, and my heart rate's 130 beats a minute, then that's tachycardia that's problematic. That shouldn't be. Something is definitely wrong with me at that point, and I mean something besides the usual. Okay, arteries, and we talked about the tunica adventitia, media, intima. The lumen is actually you can think of that as the central part of the vessel where the blood actually flows. Okay, that's the hollow part of the tube is the lumen. And then the veins are set up like the arteries, but except for with thinner muscular walls. And then the capillaries are super thin. They're thin enough to allow gas to pass in and out. Now, whenever we're looking at chest radiographs, one of the things, do y'all ever look at the reports that come along with your chest radiographs? Do you ever look at see what because my curiosity is killing me. I can't stand it. Whenever I do an x-ray, as soon as that thing gets read, I'm looking at the radiologist's report, and the main reason I'm looking is to see if they're throwing shade on my work. Because sometimes they'll say something like suboptimal images, or non-standard positioning, or artifacts due to technical factors. And, you know, of course, I'm like, fracking. You get in here and do the x-ray. You know, I want you to come down here and show me how it's done with a patient that won't hold still or is like cussing me out while I'm trying to position them. You know, that's what I want. But no, that never happens. You know, just throwing shade from afar. But do y'all ever look at your reports to see?
Don't usually have the access.
You don't have access? Your CI can probably hook you up with access. Did you say you do see yours? Okay. One of the things that the radiologist always puts on a chest x-ray report is the heart and great vessels. Heart and great vessels or cardiac vasculature appear within normal limits. You know, that's something that they'll mention. Now, if somebody's got an outsized heart, then they'll mention that too. You know, possible cardiomegaly or congestive heart failure. What are the great vessels anyway? There's some big old blood vessels. Superior vena cava, inferior vena cava, pulmonary vasculature, aorta and accompanying branches of the aorta. Those are the big valves that are close, or the big valves, the big vessels that are close to the heart. Vascular lung markings. If a patient has pneumothorax, how do we know it? Well, one of the ways is there's an air space there with no vascular markings. All it is an air bubble without any real lung tissue. And then pulmonary emphysema. Sometimes a patient's lungs are hyperinflated, but we still can see the lung markings. So that's telltale for emphysema. Some people have scoliosis. Some have pectus excavatum, which is basically a congenital defect where your sternum is pushed way back into your chest. And that can show up on an x-ray, especially on a lateral chest x-ray. Technical factors that we use: high KVP, relatively low mass, very low time, because we want to do stop motion radiography. We don't want to see any motion blur that's associated with the heart, which is more or less in constant motion. Geometric factors. If a patient's leaning towards the board or leaning away from the board, then we're going to have shape distortion on the organs. That's not good for us. Some patients are a little bigger than others and hard to penetrate. And then whenever we're doing our image critique, we're always making sure that we can see. One of the main things I'm looking for: can I see the vertebral bodies through the heart shadow? If that's a yes, then I have sufficient penetration. If that's a no, if the heart is just a white blob, then more than likely what happened? My KVP was probably too low. So even though the lung fields are fine, because they're easy to penetrate, all you need is like 60 kVp to penetrate through the lung tissue, but you need higher kV than that to get through the mediastinum. The mediastinum. All right, what's wrong with this x-ray?
Costophrenic angle cut off on the right.
Absolutely cut off. And yeah, this heart shadow is nothing but a big white blob. We can't see the vasculature of the heart. What's wrong with this picture? Not sure, but something's not right. Like instinctively you know that if you see this, if you just took a chest x-ray on somebody and this comes up on the monitor, yeah, you know something's not right here. Okay, what kind of disease do we know of that likes to cluster in the apices? Yeah, tuberculosis. This is somebody that's got a pretty far-gone case of tuberculosis. They need treatment in a major way. What do we do for tuberculosis anyway?
Antibiotics.
Yes, okay, yeah, we treat it. Okay, good answer.
Actually, can you back up one?
Antibiotics.
Does he have a skull and crossbones for his?
Yep. Whoever took this x-ray has got like a pirate flag on his marker. Now, okay, there was a rascal that worked at New Hanover. He was a travel tech from Oklahoma, and his markers, instead of his initials, his markers said XXX. That was just his personality. He was kind of a joker. He was a good guy, though. Nice guy and an excellent x-ray tech. Rated X. Okay, what is this thing out here?
Aorta.
Yeah, exactly. Anything wrong with that aorta?
A little big.
Yeah, it's a little on the big side, isn't it?
That's
Problem there. And you can see right here, this is not the same image as this, I don't think, or from the same patient. This is just another kind of aortic aneurysm, but this one here looks like it's mostly blood clot. And here are a couple of MRI images. And okay, this one over here, if you're looking for something wrong, then you're not going to find it. This is just like a cross section of the heart. And this is the aorta. Now, with an MRI, usually we don't put contrast in the patient, unless there's some reason why the doctor needs to, because the fluids that are inside the body, as long as the fluids in the body have like a little bit different composition, then they show up differently on an MRI. So it's like the difference between blood and cerebrospinal fluid is apparent even without contrast on board. Whereas with X-ray, fluids, you know, it's all looks kind of the same. And then over here, see that big, I don't know if you can really see it or not, but there's like a dark area right there. And this is the pulmonary trunk. Pulmonary trunk comes up and then it bifurcates into the left and right pulmonary arteries. And there's apparently a big blood clot right there. That's going to have to get cleared out of there, because if that thing breaks loose and goes further into the blood vessels, then it's probably going to cause a PE and wind up messing up this patient. All right, a little bit more. This is some subtraction images of a lower limb. This is before and after a declot procedure. And so you can see that like the contrast gets to this point here, and then from there on, you know, there's really none. But then once the clot has been cleared, then we've restored blood flow to that lower limb. Do y'all ever get to go in on declot procedures? Those things can be messy. Usually if I'm going in on a declot, then I drape the lower part of the C-arm, because if that thing gets bloody, man, so I've sat there on the floor for an hour with a bottle of Virex and a bunch of rags, just trying to clean the blood off my C-arm. Okay, some angiography, therapeutic, PTCA, percutaneous transluminal. Stent placement we can do, thrombolysis. I showed y'all a video last week of them doing thrombectomy on a patient's heart vessels. The guy kept going in and basically he was just going in there with a catheter and just suctioning out more and more blood clot until he got that coronary artery cleared out. Sometimes that's all it is. It's just like blood clots are like jelly that just kind of, it's just congealed blood. It's stuck there and it can be pulled out, but it just takes a little patience and knowing what you're doing. Thrombolysis, in addition to mechanical thrombolysis, we can do chemical thrombolysis by using something like TPA or streptokinase, one of those thrombolytic drugs. And embolization is something that we do sometimes, usually in cerebral aneurysms, and we'll look at those in the next unit. Embolization is where we deliberately place a blood clot as opposed to trying to get rid of one. And you would think, well, wait a minute, you know, why would we try to put a blood clot in the patient deliberately? Trust me, there are some times when we want to do that. Embolization can be very effective pre-surgical and other things too. TIPS procedure we looked at before. Transluminal angioplasty just means we're going to balloon open a vessel. Now the problem is, when we balloon open a vessel, do we actually get rid of the plaque? No, all we do is just push it out. We basically damage the vessel. We stretch the vessel open. The plaque is still there. It's just pushed out a little ways, and you know, now we've stretched the vessel so it can open. But that tissue is very elastic. As soon as we reduce the size of our balloon, what does the blood vessel want to do? Close back down. So in order to prevent that, we'll put a stent in there to hold it open. And then y'all probably do portacasts and permcasts in the in the OR about every day. Yeah, we don't typically put a portacath into ED patients, do we? That would be a very rare thing. Okay, so here's this percutaneous coronary intervention. Just going to go in with a scaffold and a balloon. Balloon it open until it's the proper size, and then once the balloon collapses and we bring it back out, we're left with that scaffolding, that stent that's going to hold the vessel open. Now, the stents that we use nowadays, almost all of them come preloaded with an anticoagulant, like an anticoagulant coating on the wires, so that they don't wind up causing yet another problem if platelets were to collect on them and cause another. And this is just an image of contrast and then The doctors inflated the balloon. And this patient has had, they've had surgery before, haven't they? They have got sternal staples. Well, we call them staples, but in reality what it is just like stainless steel wire that's just been, it's kind of like a twisty tie that gets left in there. All right, now fetal circulation. In the fetus, the baby has a patent foraminovalle that's supposed to be there, and they also have an open ductus arteriosus. Those are totally normal. Those are supposed to be there. I can't remember the number of babies that are born each year with cardiac anomalies. It's not a super high number, but it's always, well, almost always, something that needs to be addressed sooner than later. Why do babies get born with heart disorders? Well, there's some different things that can happen, you know, genetics. Some people are just predisposed to that kind of thing. Excuse me. And then you start asking the parents, and it's like, oh yeah, you know, my great aunt had the same thing, or my grandfather had this heart condition that bothered him his whole life, or whatever it was. Another thing is this. If ladies don't know they're pregnant, you think, well, you know, why would somebody be boozing it up while they're pregnant and give the baby fetal alcohol syndrome? Well, sometimes women don't know they're pregnant, and so they're still going out partying and stuff and having a big old time, and maybe not just drinking alcohol, but, you know, using recreational drugs or whatever. And then by the time they figure out they're pregnant, they're like, oh crap, and there might have already been some damage done. Another thing is, some women work in industries, like, you know, out here on, like out towards Highway 17, there's some factories out there where they make like plastic boxes, and I think there's a company out there that makes laminated wood products. They use a lot of chemicals. And so if somebody doesn't know they're pregnant, they might accidentally expose themselves to chemicals that could affect the fetus. Typically, most ladies, if they know they're pregnant, then they start taking precautions, you know, so that the baby doesn't get hurt. And they take their prenatal vitamins and all that kind of stuff. A heart murmur is just where there could be, a heart murmur could be because of a patent foraminovalle. It could also be because of a problem like a valvular stenosis. It's something that makes a noise that shouldn't ought to be there, that you can hear on auscultation. So if you're listening to the patient's heartbeat, then you can hear the heartbeat, but then you also hear like a background noise, like a, you know, sounds like somebody's like scraping sandpaper. It's like, what the heck is that? Well, that's a heart murmur. We don't know what's causing it, but we can hook that patient up to an EKG and we can probably find it out, or ECG. This is the open foraminovalle, and as you can see, whenever, because the left ventricle pumps with a lot more force than the right, and so there's higher pressure over on the left side, and so typically a lot of this oxygenated blood is coming over here, and now it's mixing and going back, and so the lungs are basically just, it's not efficient because the lungs are having to process some of the same blood over and over again. And then the PDA doesn't happen all that often. Diagnosis usually is because, you know, the baby's just not, they might even be cyanotic, but the baby has like maybe they've got like blue fingernails, something like that. The problem is, again, oxygenated and deoxygenated blood are getting mixed, and they shouldn't be. And there's that ductus arteriosus again. And here's what it looks like on an x-ray. So, right there. There's the pulmonary trunk, and this is the aorta, and there's a connection right there. That shouldn't be there. And on an MRI, it's very apparent, which is the image on the right. Okay, now, coarctation. This is that business where as the child starts growing, a section of the aorta, for whatever reason, doesn't grow. You know, the size of the aorta is not supposed to be the same now as it was whenever you were 5. You know, your body's all your organs are supposed to grow along with it. But occasionally, somebody will have an area of the aorta that just doesn't grow. It stays thin. And so it winds up being a stricture. It can be fixed. And there is a clamp. Okay, I know there's a coarctation on there somewhere, but now I can't find it. Okay, atrial septal defect we talked about. Ventricular septal defects are more serious, but they're more rare. And again, the cause, a lot of times it's idiopathic. We don't know why somebody had it. It could have been exposure to chemical or something when they were in utero, but it's a problem. This is this is an atrial septal defect versus a ventricular septal defect. Both bad. And easily correctable. Now, this is something that is really bad. This doesn't happen very often. Only about 5% of cardiac anomalies fall into this category. But in this case, this is a deformation, and at first when you look at it, it looks like there's nothing wrong, but then when you look closer, you're like, oh yeah, okay, I can see where that would be an issue. What's happened is the aorta comes off the right ventricle, and the pulmonary artery comes off the left ventricle, so the vessels are switched, okay? And so what winds up happening is there is no mixing of oxygenated, so the blood that's in pulmonary circulation is just going around and around and around, and the blood that's in systemic circulation is just going around and around and around. And the two sides are completely separated from one another. There's no crossover in the pulmonary circulation like there's supposed to be. And obviously, this has to be corrected very quickly because the systemic blood flow is not getting any fresh oxygen at all. So, and this is an interesting, I love this picture. Okay, this is where the doctor has injected some contrast into the inferior vena cava, and so you can see the blood flow up into the right side of the heart and then straight back into the aorta. So there's no going into the lungs at all. And yeah, this kid will die. They're going to have to go on a heart-lung machine like pretty much immediately after birth. And this is going to have to be fixed. So that little guy is going to surgery right away. Tetralogy of Phallot. 4 issues combined in one. Okay, ventricular septal defect, stenotic pulmonary vessel, an overriding aorta. The aorta is supposed to come off the left ventricle. Instead, it's getting fed by the left and right ventricles, so it's sitting right there on the septum. And then there's a heavy right ventricular hypertrophy. I've been working on my pronunciations. Okay, valvular disease. How do we know somebody's got a problem with their valves? Well, you can hear it on auscultation for sure, but they're having problems, you know, they get out of breath really fast. That's dyspnea. They're fatigued, they're tired all the time. They might even be fainting, having occasional chest pain. Something's not right. So diagnosis, how do we diagnose this? Well, we might be able to hear it or find it on an echocardiogram. Right here at CFCC, we have a school of echocardiography. It's ultrasound that's used to image the heart. And then invasively, what can we do? Well, minimally invasive. We can put contrast into the patient's body, and then we can see if those valves are narrowed or deformed, if there's something wrong with them. And then there's a condition called rheumatic fever. If you get that, for some reason it loves to nestle in the heart and it'll cause damage to the vessels and the valves. Okay, so sometimes people have a mitral valve or any of the valves in the heart can be stenosed. They're just more narrow than they're supposed to be. This is totally reparable. Some vessel or some valves will prolapse, especially if those cords that anchor it down are broken. And any kind of valvular damage can easily be treated nowadays. They have, and I will try to, in just a minute, we'll take a break. I'll try to find that. There's like a really short video that shows the placement of like putting an artificial valve in where you don't have to take the old valve out, which that's something new. They used to, if you needed a valve replacement, they would have to take the old one out and then replace it with either a mechanical valve or a porcine valve. But they have this new system, I think it's by Amplatz, and they just go in there and basically angioplasty that valve open. They stretch it open as wide as they can get it, and then they deploy an artificial valve inside the remains of the regular valve. And they've had a lot of success with this. And this is somebody this is obviously a lateral chest x-ray, and this person has had 2 valves replaced with the old style ball and cage valves. They used to use these things for years. This was considered a state-of-the-art valve replacement. And all it is like a silicon ball inside a stainless steel cage, and the ball is able to travel back and forth, but it's a valve. And you might have had one of these on your snorkel when you were a kid. If you ever had one of those old style snorkels that had a ball in it. Okay, so you guys, let's take a break for just a few minutes, and then we'll come back and probably finish off the rest of this presentation. The other day I started watching some Predator 2. I didn't finish it though. I love that movie.
Classic.
It is great, isn't
Hope
it?
you read.
Yes!
Yeah.
He was ready, all right.
Bill Paxton.
Yes, man, one of my favorite Bill Paxton roles. Surveillance is my specialty. Everything was his specialty. And Morton Downey Jr. was the reporter. Oh, that was so. He died not long after that, I think.
Yeah, he didn't live long.
Yeah, well, he was hard smoking, hard living. All right, y'all, congestive heart failure, which I hope you never get, but in case you do, there's several different flavors here. We can have left-sided, right-sided, or bilateral CHF. Now, regardless of how it starts out, left side, right side, it usually eventually winds up with the whole heart starting to fail because, as one side goes, so does the other. Left-sided CHF typically is caused by hypertension, valvular disease, or coronary artery disease. Could be other causes too. Symptoms, most of the symptoms are going to have to do with pulmonary edema. You're going to wind up having a lot of fluid buildup in the lungs because of this. Right-sided CHF. This can be the result of any kind of fibrous tissue buildup in the lungs. In other words, scar tissue in the lungs that make it more difficult for the heart to push blood through that lung tissue. Could be caused by COPD, chronic bronchitis, or emphysema. Pulmonary hypertension. Could be caused by valvular disease too. For right-sided CHF, the symptoms are typically peripheral edema. People have pitting edema of the lower limbs. And radiographic appearance is going to be an outsized heart shadow like this. If you look at an x-ray, you can see, okay, well that guy's heart is a little large. It shouldn't be going all the way over to the costophrenic angle. That's kind of a telltale for CHF. Cor pulmonale is a result of CHF in conjunction with pulmonary hypertension. what winds up here is the heart is just having a worse and worse time trying to push blood through the lungs, and so the heart keeps expanding the right ventricle, right ventricular hypertrophy, in an effort to push more blood through the lungs. But since the underlying cause is scarification or some other kind of congestion in the lungs, no matter what the heart does, it's never going to win this battle. You know, it's just going to keep getting bigger and less efficient. And this typically shows up as right ventricular hypertrophy on an x-ray. In other words, the left side of the heart shadow might look pretty normal, but the right side is like bulging way over into the right lung field. Atherosclerosis we were taking a look at. This is the most prevalent disease in human beings. Almost all of us have, maybe not y'all because you're so young, you know, you're just kind of getting started. But I have a lot of atherosclerosis. If you look at my C-spine x-rays, you can see my carotid arteries clearly because I've got a lot of deposition in there. For some reason, and I know it's because of blood pressure, the aorta, these blood vessels here, the aorta, coronary arteries, and cerebral arteries, what do these all have in common? High pressure, high blood flow. You know, so you're going to wind up seeing a lot more plaque deposition in these areas because these arteries tend to, you know, they bulge out more. We don't really feel it when our heart beats, but these arteries carry a lot of blood, and so their diameter, they flex open, and then they like kind of shrink back down with every beat of the heart, so it just makes them easier for those LDLs to penetrate. Now, there are some risk factors that we can control. Can you name one? Yes.
Delicious
Stop
cigarettes.
smoking. What about eating a bunch of fast food?
Candy.
Like if I like candy, yeah, that's probably not a good thing. But a lot of people just really love to go to Popeyes, you know, Church's Chicken. Taco Bell? Yeah, okay, all the above. What do these foods have in common? Well, sugar and fat, you know, just like donuts. You know, what the heck, you know, donuts are just like the perfect food, aren't they? They got sugar and fat, deep fried. What, yeah, what else do you want? You didn't? For real? Have you ever, okay, you can watch them make the donuts down at Krispy Kreme. It's really cool. Or Brits Donuts, yeah. Yeah, they got the fryer going. So yeah, what it is fried dough that's had sugar put in it.
What do you think it was? Like a bagel.
Yeah, bagels aren't fried as far as I know.
Boiled.
Bagels are fried?
No, I said bagels are not fried.
Oh.
At least not that I know of. Okay, what are some uncontrolled factors for atherosclerosis? Heredity, genetic proclivity. You know, there's nothing you can do about that.
Did you turn that back on when you came back in?
Yeah,
Okay, just
yeah,
making sure.
it's running.
It's red. It's blinking. There you go. It's red.
Y'all can see me, right? Yeah, I think it's recorded. All right, some more. Atherosclerotic formation. This is a normal artery, and this is one that is very, very occluded. You think this is my artery? Oh, the dude on the video? Probably. You know, that guy had a lot of problems, didn't he? Some people form these plaques like early in life. I've heard of people having heart disease and even heart attacks in their 20s. So it's a genetic thing a lot of times. Okay, so this is going to result in, as you might well imagine, even under the best of circumstances, somebody with this much plaque in their artery, they're going to be having ischemic episodes a lot. Like every time they start getting a little bit of exercise, they're going to start feeling the pain. They're going to feel the burn, and not in a good way. You know, it's going to be their cardiac muscle crying out for more oxygen.
So what was an atheroma again?
An atheroma is, well, technically it's a tumor made out of this sclerotic tissue or plaques. So Yeah, just like a little, you know, like on that video we saw where it showed just like it's like a little bump sticking out of the side of the vessel wall. That's an atheroma. It can be big or it can be little. Cause for coronary artery disease is almost always sclerotic buildup. I mean, there's other reasons why a vessel could have a stricture, but by far, atherosclerosis is the worst. And this is coronary artery disease, single most common cause of death for men and women in the United States. Not necessarily in the world. Okay, now, coronary artery disease, how do we diagnose it? Well, labs, blood work can reveal that there's a problem. There's certain enzymes in the blood that are elevated during a time of coronary distress. Of course, we can do angiography. That's pretty much the gold standard. EKG can actually, or ECG, same thing, that can reveal if somebody has ischemic areas of the heart. A doctor that knows what they're doing can look at a 12-lead ECG and they can tell you a lot about what's going on there and where. Myocardial infarction. This is the case where this isn't just like an ischemic event. This is a termination of blood supply to part of the heart. And it's acute. It happens like that. And it could be like an embolus floating through the bloodstream, all of a sudden jams up in a coronary artery, and all of a sudden that patch of muscle goes from having blood to not having blood in just a second. And all of a sudden, this is the kind of deal where, somebody does the old, I'm coming to join you, honey, the big heart attack. Crushing chest pain, neck pain, central back pain. Sometimes people feel like they've just been hit in the back. There's a lot, and the thing is, your brain isn't used to getting pain signals from your heart. How many times have you whacked your elbow on something? So your brain knows what to do with that. You've hurt yourself plenty of times, or you've fallen, or you twisted your ankle. Okay, no problem. But for your whole life, you've probably never experienced coronary pain. And so when you do for the first time, the brain's like, what the heck is this? And so that's why people get confused. They're like, they feel like they've got a stomach ache, or indigestion. They feel like, they've got like bad indigestion. They might feel like they've got an ulcer or something. So that's why the pain comes from so many different places, because your brain just doesn't know what to do with this. It's all coming from the same place. Definitely early medical intervention. You need to get somebody to the hospital within like 30 minutes of the onset of a heart attack if you want to really help them. It's got to be quick. That's why the ambulance service, they have a phrase called scoop and run. So if they show up on the scene and somebody's having a heart attack, most ambulance drivers aren't going to sit there and futz around, trying to establish like an EKG and push medications and all this kind of stuff. It's just going to be, okay, let's get in the ambulance and go, and we'll treat what we can en route. But the main thing is to get to a chest pain clinic fast. And here's some of these chemicals that are elevated in the blood, that whenever you get a patient into the hospital, one of the first things they do is check their blood. What's going on? Do they have any of these elevated enzymes, or do they have a problem with any of their electrolytes? What if somebody's got like way reduced calcium, or too much calcium, or they don't have enough potassium? That can definitely cause somebody to have coronary symptoms. It might not necessarily be a blockage. It could be that their electrolytes are out of balance, and that's causing their coronary issue. So a lot of different things that we can do for somebody once we get them to the hospital and we can actually look at them and see what the heck's going on there. If it's a real MI, then thrombolytic therapy. TPA, what year was TPA brought into by the FDA? I think it got approved in like the late 80s, maybe mid 80s, something like that. Ever since that stuff got approved, it's been the go-to medication. Tissue plasminogen activator. What that stuff does is it causes the fibrin, like if there's any fibrin in your blood, like any clots, it causes that stuff to immediately release. It's a strong thrombolytic. Okay, aneurysms. This is a bulging of a vessel wall. Can be caused by several different things. Can be caused by sclerosis, actually, trauma, infection, could be just a congenital proclivity. Some people are just naturally prone. Their tissues aren't as strong or resilient as others. Another thing that can cause aneurysms is people that have Marfan Syndrome. You guys remember that from, I don't know, like Rad 111?
Yeah.
You know, we talked about Marfan Syndrome. Okay, that is a congenital issue or a congenital condition where all your connective tissues are loose, including the connective tissue that makes up your circulatory system. Several different classifications of aneurysms that we're going to take a look at. Now, whenever we're looking in our next unit at cerebral, we're going to see a lot of these saccular aneurysms. These things form in the vessels of the brain all the time, and a lot of people are walking around with them and don't even know it. Fusiform aneurysm is what typically takes place in the abdominal area, distal abdominal aorta, below the renal arteries. And then there's such thing as a dissecting aneurysm. In this case, the intima peels away from the rest of the vessel wall, and then blood can flow down into the vessel wall as well as the lumen of the artery. And I've got a couple of pictures. Okay, now, this is just a little cartoon kind of showing what this thing does. Okay, this is a circumferential fusiform aneurysm. In other words, the entire vessel is bulging out. So it's like all around. It's not more on one side than the other. A saccular aneurysm, there's just like an area of the vessel that's outpouching, and if this thing starts getting big enough, you know, it can balloon and balloon and wind up being like a huge bulge. In that case, we call that a berry aneurysm because it looks like a berry. The false aneurysm is this. There's a break in the vessel somewhere, and some blood has escaped into the surrounding tissue. And remember, inside your body, it's not just like a wide open spaces. You know, there's a lot of other tissue in there. It's all kind of together. So if this blood escapes, it might not go very far. It could form like a big clot on the outside of the vessel. And in that case, on an X-ray, it looks like an aneurysm. But then you start to study it a little bit more and you realize it's really not. That's a false or a pseudo-aneurysm. And then the dissecting one is where we've got a hole just in the inner lining, but the outer lining is still intact. Okay, this is an abdominal aneurysm. Right there it goes. It's a big bulged area. And this is by far the majority of the aneurysms we see. AAA, abdominal aortic aneurysm. Thoracic aortic aneurysm, not as popular, but can be very dangerous. Because remember, this is at the top of the aorta where the blood pressure is really high. This can be congenital, somebody was born with it, or they could have gotten some blunt trauma to the chest. That's entirely possible. Diagnosis typically by ultrasound, CT, MR. It can show up on a chest X-ray. Absolutely. And it might need treatment, it might need repair, it might need surgery. A lot of times if somebody has an aneurysm, what the doctor will do is go in there and deploy a sleeve. And we have software at the hospital that can actually enable the doctor to take a CT scan of somebody's aorta, and then they can do like a 3D reconstruction and send that off to the company, and they will make the patient a custom sleeve that fits into their aneurysm exactly. And so once it's in there, then the patient's usually good to go, because the vessel just needs that reinforcement. And here's an image of a dissecting aneurysm, and this is a coronal image, and you can see that the intima is torn and is peeling away from the rest of the vessel. So blood is getting in between the intima and the rest of the vessel wall. And this is it on an axial image. In the extremities, it is possible for people to have aneurysms in the lower extremities typically. Most of the time it's in the popliteal fossa, the popliteal artery. And usually people that have these aneurysms in their legs, they've got a history of forming aneurysms other places. So they might have had a AAA at some point in time. And venous thrombosis, this is DVT formation. Blood pools in the lower extremities. Why? Well, the way your system works, you've got a heart pumping blood into the arteries. What pumps the blood back from the veins? Once the blood's been through the capillaries and it's slowed down to a very, going through the capillaries, the blood flow is very slow. And then it gets picked up by the veins, where again, the blood flow is very slow. Coming back up the legs, coming back from the arms, what causes the blood to go back towards your trunk?
The blood pushing down causes the blood to push up.
Kind of. That's part of it. But the majority of it is your leg muscles. As you're walking around, as you're moving around, your leg muscles are contracting and expanding, how muscles do. And when that happens, they squeeze on the veins, and the veins have valves in them every so often. And so the action of your just walking pushes the blood back up towards your trunk. Now what happens if all of a sudden somebody's been in a car crash and they've got a broken leg and they're laid up for a while? What are they not doing? Walking, unless they absolutely have to. So now that the patient is stationary and sitting there not doing much, what's going to wind up happening? Well, they're not getting that good circulation anymore. Blood can pool in the veins and it can start forming clots because the blood flow is just not there. This can also happen to people, y'all may have heard about this, people that do a lot of traveling for a living and they go on these really long distance flights and they can't really get up and walk around much during the flight, so they're just sitting there. They are notorious for developing DVTs. So one of the downsides of traveling for a living. So injured or bedridden patients, very common. A lot of now, and this is a new thing, and when I say new, I mean like within the last 10 years. When patients come into the hospital, if they're like bedridden, they're not able to get up and walk around very much, they will go ahead and start like something like Plavix or even heparin prophylactically. They'll go ahead and start giving the patient blood thinning drugs to try to head this off because, it's a known issue. Phlebitis and thrombophlebitis, those are both vein inflammation. Phlebitis is just inflammation of a vein. Thrombophlebitis is inflammation of the vein in conjunction with blood clot formation. Okay, so how do we diagnose this thing? Sonography. Once upon a time we did something in the department called venography. What we would do, and I know this sounds like craziness, we would bring a patient into the department and get them up on a table like in room 7 or room 8, and then we would tie tourniquets onto their leg and because when you tie a tourniquet on, what you do is you restrict the superficial veins, but you leave the deep veins open. So then we would inject contrast into the patient's foot, and since we had a tourniquet on their foot, the contrast would be forced to go through the deep veins, and then we would be able to spot any blood clots. It was a pain, not very efficient. Sonography with Doppler, much better, and much easier on the patient. Doesn't have to really do anything with ultrasound. You just have to lay there while the technologist runs the probe up and down your leg. Now, treatment. How do we treat a venous thrombosis? Well, we want to get this patient up and exercising as soon as possible. If we can get the patient moving around, that's going to solve a lot of our problems. Other than that, blood thinners, anticoagulants, and the placement of Ivc filters. And that's what this is. I don't know, can you guys see this? There's like see that thing there that looks almost like a Christmas tree? That's a filter in the inferior vena cava. The idea is if this patient does throw a clot, hopefully that filter there is going to catch it and give the body time to thrombolize it before it just goes straight up into the lungs or into the brain. Either of which would be a big disaster. And right here looks like an area suspicious for thrombosis. All right, so a little summary. Additive pathologies. A lot of these cardiac pathologies are neither additive nor subtractive because the heart was already full of blood to start with. There are some exceptions. Coarctation, septal defect, tetralogy of Phallot, this can cause increased density of fluid in the mediastinum, and so that's considered as additive. Valvular disease, same kind of thing. You know, it causes blood to back up. Congestive heart disease is additive because it's usually accompanied with cardiac hypertrophy. So there's just more tissue there to penetrate, and same thing for cor pulmonale. You know, it's causing an increase in the volume of heart tissue, which we usually don't have to deal with, but there it is. So we might just increase our KVP some to make sure we can shoot through all of that tissue. All right, the chamber located most anteriorly and forming the anterior border of the cardiac shadow on a lateral chest radiograph. You're thinking left ventricle is most anterior?
I'm thinking right.
I'm thinking you're right. The way the heart is canted, the right ventricle is actually a little more anterior. And you can kind of see it on a lateral chest x-ray. You can really see it on a CT scan. You know, then it's pretty obvious. Bicuspid valve is also called which? Anybody want to take a guess?
Aorta? No.
You're guessing
no.
A?
Bicuspid?
Yes, bicuspid,
The mitral?
which is also the mitral valve.
Yes. Left.
Very good. A, the left atrioventricular valve. Contraction of the myocardium is referred to as systole, diastole, something else? Very good. Systole, systolic. In a fetus, the Ductus Arteriosus connects which two structures? If you don't get this one, you're fired. Ms. Hope. Does anybody want to take a stab at it? B. I agree. The aorta and the pulmonary trunk. And in a fetus, this is totally normal. That's how it's supposed to be. In a full-grown adult, this would not be a good thing. Tetralogy of Phallot includes which of the following? Pulmonary stenosis, ventricular septal defect, hypertrophy of right ventricle. What do you think? Does any of that sound familiar?
E.
All the above. And there's one more that goes along with it, which is the overriding aorta. That would be tetralogy part number 4. Okay, what is the single most common cause of death in the U.S.? C. Coronary artery disease. And not by a small margin either. In our next unit, we'll take a look at some causes of death. It's pretty amazing. Which type of aneurysm results when the intima tears and allows blood into the vessel wall?
D.
Mia says D. All right. Dissecting. Very good. Very good. turn off my video. Thank you so much for joining us. Be sure to tune in next week when our subject matter will be cerebral angiography.
Smash that like button and subscribe.
Don't forget to smash that like button and subscribe. All right, everybody. Say good night, Gracie.
Good night, Gracie.
All right, here's all your classmates. They say hi. They send their best. Yeah, even this guy.